Well, good afternoon, everyone. Good morning for those of you on the West Coast. Thank you for joining us for this AAA American Rescue Plan Act of 2021, what every ambulance provider needs to know. I appreciate you joining us. As always, of course, these sessions are recorded. And just so that folks are aware, we will be sending out a copy of not only the recording, but also a copy of the slides with Monday's Daily Digest. So you will see that coming through. We used to send them out, but the problem is oftentimes many emails were bouncing back, and frankly, it's just easier for us to plug it into the Daily Digest, which has a whole bunch of important information that you have to pay attention to anyway. So you will see that coming out on Monday. Additionally, if you'd like to interact during this session, which we encourage, first of all, the chat box there, the chat feature in Zoom here is really intended for sort of informal conversation. Right now, you'll see in there the AAA's treatment in place survey that we'll get to in a few minutes, but we certainly encourage all of you to take that survey. In addition to that, the chat feature is intended for sort of the more informal communication between either the speakers or those in the platform, as well as the Q&A. What we would ask on the Q&A is that if you have a question, please plug it into the Q&A feature, and what we will do is try to answer those questions as we run along during the platform, and certainly be answering those if we can. If not, we'll grab them at the end. And then for those that for whatever reason, we got a lot to cover today. For those that we aren't able to get to, we will get to following the program. So I just want to welcome my co-presenters, Mr. Asbel Montes, as well as Mr. Brian Werfel. Thank you. It feels like we've done this before, maybe 30 or 40 times over the last year. So we are back. So as always, these guys act a little bit like the safety net under my High Wire Act. So I appreciate it. And I will be passing it off to them in just a few minutes. This session, as always, this session's intended for educational or informational purposes only. We're not giving certainly accounting, legal, or other advice. What we're really doing is intended to educate you about what was in this particular piece of legislation, so that if you do in fact require more directed either legal or financial advice, we recommend that you reach out to a licensed professional within your state or jurisdiction. So our plan for today is we are going to talk about the American Rescue Plan of 2021, and we're going to just really try and highlight, we'll first provide a little bit of coverage on what the bill provided. We can't hit all of it because it was 600 and some odd pieces of legislation, pages of legislation, but we will touch, really we're focused on the EMS impacted ones. So treatment in place, which we will get to and spend some very specific discussion on that, because this is going to be a really important part of this legislation, specifically, for our EMS providers and with implications, I think, down the road. Additionally, that we will talk about the small business provisions that were in the latest piece of legislation, some workforce and workplace provisions within the bill, a little bit on provider relief, which played a huge part in prior pieces of legislation, not as much in this one. And then some of the other Treasury funding options, and then just a few other key points as we move along. So just as we get started, what we wanted to do is just provide just a general overview, and you're going to see some repeating features here on the next slide as well. But this was a $1.9 trillion, that's my typo on there, $1 trillion package, one of the biggest packages certainly passed so far during this pandemic, regardless of administration. Some of the provisions that were important, of course, were treatment in place, or payments for treatment in place, $8.5 billion additional dollars in the provider relief fund, some increased funding for the PPP and EIDL, or the SBA lending programs, as well as an extension of the pandemic unemployment assistance, which, of course, that additional money that was added, and an extension of that through September. Some funding for support for first responders and other essential healthcare workers, and COVID-19 vaccination programs, as you would expect, testing and other contract tracing and mitigation programs, and an extension of some of those important tax credits that are provided to employers, and then some funding for Fema and some other economic development programs. So the parts that we think are specific to EMS are, in particular, probably one of the most important pieces is this treatment in place funding, which Asbel and Brian are going to tackle in just a few minutes, but wanted to be everywhere you see this, we're going to talk about some restrictions that are tied to this provision within the bill. Really, the devil will be in the details when it comes to this part. That, of course, there is an opportunity for additional provider relief funding, although we know that many folks have already applied for prior tranches and maybe have did not receive funding. So that part's probably not as big of an impact for EMS agencies. The PPP loan program, the SBA EIDL loan program as well, a huge chunks of money being pushed back towards that, although no extension in the deadlines for applying for those PPP loans. I think, if one of the things that I picked up from this, reading this piece of legislation, was a little bit of the sense of urgency seems to be quieting down in a sense that maybe we're winding down in general on the pandemic, despite a lot of those restrictions being in place. $350 billion for, again, supporting first responders and other essential healthcare workers, or other essential workers, not just healthcare workers. That return or an extension of those employee retention credits, as well as the Family First Emergency Leave tax credits. $200 million funding for DOL oversight. I'll talk about that a little bit later on in the program. $50 billion in those FEMA funds, as well as $4 billion in expanding behavioral and other mental health services. So I'm going to pass it off to Brian and Asbel to talk about what I think is probably the single biggest piece of this legislation, which is the treatment in place. So Asbel and Brian.
Brian, you want to go first?
I will. So I think what the way Asbel and I will divide this up is I will just speak in terms of the actual nuts and bolts of what's in the legislation, and then I will turn it over to Asbel for a more detailed analysis of what this likely means to all of you. So in terms of what is actually in the bill, it's, I think, easier to talk about what this treatment in place provision is not, and then we'll get into what it actually is. So what it is not is a fundamental reordering of the Medicare reimbursement for ambulance services. So this is not implementing treatment in place as part of the Medicare program under normal circumstances. Rather, what this is doing is giving authority to CMS that CMS can choose to exercise or not exercise under its 1135A waiver authority. And if CMS elects to implement the waiver, then what it would be waiving is the transportation requirement that is normally applicable to Medicare's coverage of ambulance services. So what it provides is that if CMS elects to implement the waiver, it will allow for for Medicare payment for EMS services that you furnish, even despite not otherwise providing a transport, to the extent the reason you do not transport the patient is because there is some restriction in the established community protocols that prohibits you or offers you the option to not transport that patient in that circumstance. And when we talk about those community protocols, these are the community protocols that are implemented in response to that particular public health emergency. So to the extent it's implemented for the current public health emergency, it would be those changes to those community-wide protocols meant to deal with COVID, right? It's not limited to COVID. It can apply to any declared state of emergency. It's just right now we're currently focused on COVID. So that's what the bill does in a technical sense. And Asbel, you want to sort of analyze it a little bit?
Sure. So I think it's probably the easiest way to describe too is if you remember when the pandemic started and many communities were beginning to receive instruction from either their Office of Public Health. It could have been on a regional basis. Especially we saw this really starting where the hotspot started originally. So New York City and the Bronx area, where it was because of surge capacity issues, exposure to COVID for low acuity conditions that we're calling the 911 system is we want you to treat these patients in place. Do not transport unless they are in some critical emergency that needs to come to the hospital. Treat them in place. And we tried to get this passed through CMS, and they indicated they did not have the authority to do that. And so this, folks, is the outcome. This is what Brian's talking about, that we now gave them authority. You do now have it under the 1135 waiver authority to allow for this. So that's the first hurdle that we have to cross. Number one, we've got to get CMS to now access the authority that they now have. So they can no longer use that as an excuse that they do not have the authority to reimburse us for those transports. Now, second thing is as Brian was indicating earlier, it is not just carte blanche. Now you can treat in place. You've had protocols in place. Some of you guys have been doing this and demonstrating this across the United States for a few years now and have not been getting, because you've been trying to take the low acuity calls out. Maybe you're a part of the ET3 program and you applied for that, or you're not. That is not what this is. And we got to be very careful. And the reason why we're saying this is because there is scuttle happening out that, oh my goodness, treatment in place is now covered by this law. And so now we can go ahead and get reimbursed as long as my community protocol is indicative to treat in place. That is not the case here. So number one is the exercising of the waiver authority, and it is subject to your protocols being updated to reflect that the reason why you're treating in place is because there was a directive because of either surge capacity, there was issues with the hospital to keep them away from the exposure for conditions that maybe could be treated in place and passed off through either their primary care physician following up with them later, what have you. So think through the process of what happened in New York City at the very beginning of this pandemic. Many jurisdictions begin to adopt this in May and June, July, and August because surges and second and third surges started happening. That is what we're saying here. And then there's going to be documentation that's going to be required. And so I like to refer that too. So if we hit that first prerequisite, CMS exercises the authority. Hopefully we'll get it back retroactive to those who had mandated protocols that said you have to do this. You do not have an option of taking patients to an emergency room for those low acuity conditions. You could maybe retro to March the 14th. Some of you may go back to June the 1st. If some of you are not operating off of written protocols that were updated community-wide, that's different than I'm in an area, my service updated the protocol, but maybe you have a state medical society that has to sign off on your protocols that governs 5 counties.
So Asbel, let me paint a hypothetical, and I'd like you to just sort of opine on how you think that this would work in the real world. So let's assume that in my area of New York, and again, I am in New York, and in New York, we had this major concern at the beginning of the pandemic that if something wasn't done, we would run out of capacity at our ICUs. We would run out of ventilators. So let's assume that my existing protocols allow me under certain circumstances to treat a patient in place and not transport them. And the example I'll give is a diabetic crisis, right? So under my existing protocols, I can respond to this patient, I can intervene, and assuming that they're otherwise stable at that point, I have the option of leaving them in place, assuming that they consent to that. And now let's further assume that during this pandemic, so up until the pandemic, I had the option to leave the patient in place. Now let's assume that as we worried about hospital capacity, I am now told by my regional EMS council here in New York. So it's not my company, but the state's designated oversight body that changes my protocols to now say that that diabetic crisis, unless there are certain aggravating factors, you must leave them at the scene, and then suggest they contact their physician, etc. And now let's assume that the day after that protocol is changed, I respond to a diabetic crisis and I now leave them in place. I treat them in place and I leave them in place. In your opinion, would that fall within what we're talking about here, which is community-based EMS protocols that were adopted in response to the pandemic?
You are exactly correct. That is exactly what this would follow as a community-wide protocol. And that was the intent of the waiver that was exercised and the language of the community-wide protocol. And that's why you see it very specifically say in the regulation that but such transport did not occur as a result of the community-wide emergency medical service protocols due to the public health emergency. That's the reason why it says that.
All right, now let's give a or counterfactual, which is my protocols prior to the pandemic said I must leave that person in place. And now they change the protocols to say, in addition to that diabetic patient, you must also leave those that are having minor, well, behavioral issues, anxiety, etc., but where it's not manifesting itself with a physical symptom. And now I respond to that diabetic patient. And now I treat them in place and leave them. Would that qualify? So before the change in the protocol, I had to leave that person in place. After the protocol, I still must leave that person in place. Treat in place.
So they changed and it's all due to the public health
added
emergency.
Different conditions where I can leave them,
Yeah.
but this one
and that's fine.
always mandated to leave them.
Correct. And that would be okay because it's all related to the public health emergency.
Well, hold on. So I may not have explained it well. So
yeah.
I'm told before the pandemic, you must leave that diabetic person, treat them in place, and don't transport them. And now they're saying, because of the pandemic, in addition to the diabetic patient, now also leave other conditions. But I'm still responding to that diabetic patient.
Yeah, but so your protocol have been amended because of the public health emergency. They've been amended as such. So yes, it does include everything at that point in time, as long as it's very specific what the amendment to your protocols are. So if you were doing this pre-pandemic and your protocols were amended that it's these conditions as well as these conditions.
During the pandemic.
Right. Correct. Now, if they come back and say tomorrow, hey, we're amending now, you no longer need to do that anymore. Well, guess what? That's it. You're done.
All right. Now, what if they say that you don't have to transport diabetic patients, anxiety, etc., and that's all they say, but now I respond to minor chest pain and the patient doesn't want to go. I treat them in place and leave them. It's not mentioned in the protocol.
So if your community-wide protocols do not indicate the conditions of the public health and it excludes certain conditions, it only will cover the treatment in place for the conditions that are mentioned in the community-wide protocol.
Right. So you've heard
we keep saying community-wide protocol because there's certain jurisdictions in the United States that it's regional. There's some that are very local. So it just depends on where you at and where you're at and and how that is established is going to determine what you can bill for.
Right. So
and I will tell you that. Go ahead.
I was going to say, Asbel and I have talked about this but-for analysis in a lot of situations. So what we're really talking about here is a situation where but for a change in the protocol as a result of the pandemic, right, you would not have normally left this person in place, right? So that's what they're attempting to identify is the change in your behavior due to the protocol, and the protocol is due to the pandemic. If it doesn't meet all of those boxes, this is not a blanket treatment in place.
No, it isn't. And then there's the easiest way when people are talking about, well, what about documentation? What about certain billing requirements as well? I like to equate this to folks. If you've not been doing treatment in place and it's been a requirement of y'all, think of it like an AMA. When you're going out there to get information relative to an AMA and your documentation, that's probably the best analogy that I can give you. There'll be a few other disclosures that you're getting. There's a lot of other stuff that we need to cover through this process as well. There are certain things that, especially for billing agents, I'm going to do an extensive deep dive into how to bill for it, if that's the case as well. But because we've got a lot of things to cover through the process, we just want to make sure that we hit home for you that this is not a carte blanche treatment in place waiver. It is very restrictive based upon how your community-wide protocols have been developed. And I will tell you this, when we were actually talking through, that was not the original intent of trying to get it done. This is what we ended up with. And so it does allow for there was a concern by Congress that there was going to be some abuse to this factor as well. And so this is why they got it so narrowly tailored around these community-wide protocols. And so we're stressing that for a reason as well. Scott?
Right, so Asbel, let's talk about what those protocols are. So I think we are in agreement that we are not interpreting this to mean internal protocols. Right? These are those protocols that are established by whatever oversight agency is authorized under existing state and local law. Now, that can be your organization. if state and local law expressly delegates to your organization the authority to establish the protocol. But the more common model is a protocol that may be developed by you, but then must be approved by, in New York, it's the Regional EMS Council. In some states, it may be the State Bureau of EMS or Office of EMS. So this is
That's why
internal protocols.
you are exactly correct on that. And that is key to know, because there's only a few states that, like the state of Texas, they give that up to each of your jurisdictions because of how that is. But most are going to require some type of council. Either so there's some that it's a statewide protocol, like yours, it has to be approved by the state. So Brian, that's a fantastic point. That's what we keep saying. Understand whoever approves. If you do not already have that done, you probably won't see a retroactive. You would have to work with your state or your local or whoever that is that agrees, that says this is a protocol that we need in this community to make sure we preserve surge capacity and what have you. If you do not have that, it's the effective date of that community protocol that you've had developed that you can be able to prove to your MAC or to your RAC regarding that.
Right. So we've gotten a number of questions that go to whether or not CMS will implement the waiver retroactively. And I think the short answer is that ultimately we don't know what CMS will do. Is it possible that they will go retroactive for the effective date of the waiver? Absolutely. But again, just because they go retroactive to the effective date of the waiver doesn't mean that any treatment in place that you provide will be eligible, unless your established protocols were in place prior to today. Asbel, one other question that I just want to throw out to you to help people: does this apply to any treatment in place situation, or is this only limited to certain types of responses?
Remember this, it's not reflective of just COVID or anything. The intent, and people have to remember this as well. And we're getting some feedback as well regarding other people nuancing through the regulation. Remember, this is not amending, as Brian said earlier, the way that we get reimbursed. This is amending and giving them waiver authority to CMS. CMS can take that waiver authority at that point in time and say, I'm not going to exercise the waiver and reimburse you for this, or I am. We understand with all the conversations we have with CMS that it is very restrictive what they believe should be covered under this. There's a reason why we're stressing this, because if we come out of the gate and try to make it sound like, oh, go ahead, let's nuance through this, there's unrestricted stuff through this waiver will not go. I can't stress it more. It is not an unrestricted waiver to just reimburse you for everything treatment in place if you've got a protocol. That is not the intent of what they're trying to do here. It's what we want, but it is not their intent.
Well, and so I just want to make sure we hit a couple of questions. And I think, Brian, you may have hit this, but question from Stephen: if we have no community protocols, but our hospitals were on full diversion for 6+ hours on wait times, how would something like this work? So I think fair to answer in this instance, right, that being on diversion does not meet the standard, right? There has to be a and in this instance where you're saying there's no community
unless the community protocol that was put in place for the pandemic said, if at the time you respond, and we should have mentioned this only applies to 911 responses or other emergent responses in an area where there is no 911 service. So this is not all ambulance responses. This is only emergent responses. But in the unlikely event that there was a protocol that was drafted in response to the pandemic that said something to the effect of, if at the time you respond, there is more than an X hour wait at the ED, then and only then can you leave them here, right? Or you must leave them here, right? That sort of protocol would theoretically apply to this. More likely, it's not going to be that granular, right? That is a situation where you could have transported them, but for the diversion, that, in my opinion, would not apply for this treatment.
And so as a follow-up to Steve's question, if in fact in his area, it isn't a statewide or a regional protocol, it's that the authority to develop the protocol has been delegated to the individual service. Well, then in that instance, if you're developing a protocol, that in my opinion would be use your medical director or whoever your affiliate medical hospital to make sure that protocol, but in that instance, then that would be the protocol, right? And if that protocol were amended to say, in the event that the hospitals are on diversion, right, that you're going to do treatment in place,
That's
then
exactly correct.
then that would be fine. So
that is the intent. That's exactly correct. That's the intent.
okay. And another question, Richard, if EMS agencies don't charge for treat no transport, will they be able to establish such fees retroactively? That in this instance, the treat no transport is something different, right? Most organizations right now are frequently or regularly responding to patients who might require, let's say, for example, the diabetic that Brian was talking about, where we frequently provide treatment and that diabetic then subsequently refuses transportation to the hospital. That's something different than what we're talking about here, right? In this in the instance of the treat no transport, where in most states, the only person who can refuse, the only way an ambulance doesn't transport to the hospital is when the patient at their patient's sole prompting, no outside interference, the patient says, I don't want to go to the hospital against AMA, against medical advice. That's not what we're talking about here. What we're referring to is that you respond to a 911 patient who, at the time, the list of conditions are part of your protocol that suggest that you can treat this person and not transport them to the hospital. Either you can not transport them or you shouldn't transport them, depending upon what the protocol says. And that is part of that protocol. Well, then in that instance, you would be able to, provided of course Medicare uses the waiver authority to do that. If gentlemen, am I right? Is that
you are? I would just get into the more technical part of the question, which is, can we establish fees retroactively? That's going to depend on the local environment in which you operate in. If you are rate regulated, then you likely need approval from some government entity to establish a fee in the first place. They may or may not permit you to establish it retroactively. Yeah. I would suggest, though, that, and keep in mind that presumably the fee wouldn't be adopted simply for Medicare. It would be adopted because you intend to charge all individuals for treatment in place, right? It's a little more technical than what we need to get into here, but if you only intend to bill Medicare patients because they're on Medicare, it raises legal obligation to pay concerns, right?
Yeah, but hang on, but if I can just interrupt really quick, because I think we might just be able to simplify it pretty quickly, Brian. The way that it went through this process, if somebody called a 911, you would have transported them to the emergency room. It's very specific. Right. You would have transferred them to the emergency room, but for this community-wide protocol. There is no treatment, no transport fee, as you would think. We would have transported them to the hospital, but our protocol indicated not to do it because of the pandemic and the surge capacity and whatever else was going on in your community. So you would bill them accordingly to whatever base rate you would have billed had you taken them to the hospital. So it was a diabetic crisis. You normally would have taken them to the ER and you would have billed them as a BLS emergency with a mileage. You just don't bill the mileage. You just bill the BLS emergency. It's not like you're billing a treatment no transport code at this point in time. And I think that's the easiest way. We got to get it into our mind that this isn't treatment in place as we are thinking it is treatment in place. Right. It is, you would normally have taken this patient to the ED, but for that protocol.
Right.
Yeah, it almost should be called treatment in lieu of transport.
Yes.
Right. And so I know we're getting a ton of questions on this. And one of the things I want to say is we're going to try and cover the other aspects of this American Recovery Act or recovery plan. And so we will undoubtedly, Asbel, Brian, I can foresee in the future, maybe not that far away, where there may be another webinar where we will be tackling this in a deeper dive. There were a couple of other questions, and I'm not ignoring them intentionally. Gene Bradley, Chad, Deb Galt, some good questions about, statements and paperwork. But just because we're 30 minutes into the webinar and we're only on the first issue of the second slide, I'm going to continue to move along. But rest assured, right, there are so many questions that are not answered yet, right? The devil will be in the details when this piece of legislation hits regulatory action and or administrative action.
If the waiver is executed, that's the only thing that I want to say before we move on. Remember, if we try to escape the system and we try to tell everybody, hey, you're going to get paid treatment in place, and CMS or anybody gets wind of that we're going to try to get around this system, they will not exercise the waiver.
Right.
I cannot stress that more. This gave them the ability, because they kept pushing back on us, telling us they didn't have waiver authority. They now have waiver authority.
Right.
But it's up to CMS if they want to exercise it or not.
And
Right. So we need to present the image of, we promise we won't abuse this.
That is correct.
Right. And also just keep in mind, the AAA is going to continue to work as they have all along. Part of the reason that this piece was included in the legislation in the first place was because we've been knocking on their door, asking and recognizing this is something that we need to get reimbursement for. So more to come. And I know there were a lot of questions, and I don't mean for you to sign into a webinar with us and not get your questions answered. We will grab those questions and we will answer them following the webinar. And some of them, by the way, to the extent that we have the answer, we will answer following the webinar. Others, we may say, we're planning on doing another webinar. We will certainly get back with you and hopefully we'll have more information, right? So just keep in mind, like I said, this piece of legislation permitted them to, gave CMS the authority to issue that waiver. Doesn't mean they're going to. Nothing may change at all. We're just hopeful. So I don't mean to continue to move along on this one, but we are going to. So Asbel, you want to just touch briefly on, or Brian, maybe on the $8.5 billion that's been put into or added to that provider relief?
Asbel's pointed at me, so I will handle it. Quite simply, they have added an additional $8.5 billion to the provider relief fund with the intent that this be a targeted allocation directed at rural healthcare providers. And there are a number of various eligibility requirements, and it will likely have an application process similar to what they've done with, the tranche 2, 3, and the other targeted distributions. So if you are in a rural area, just keep your eye out for an update from HHS. The AAA will also put out an update once they open up the targeted distribution there.
And the only thing that I'll add to that, guys, is some of you probably have questions like, well, wait a minute, my location is in an urban location, but I do a lot of rural transports. Does that mean I qualify? The secretary does have the authority to include other things. I will tell you, there's a provision for home health because of that and their mobile that they made. We will be advocating that they allow for that as well, especially for providers who may not have their practice location in an urban area, but they are doing a lot of rural transports as well, that would be something we'd want to advocate for.
And one other thing that I'll mention is, and we joked about this prior to the beginning of the webinar, that if I could count the number of times in this webinar that there was a reference, or in this piece of legislation, a reference to rural and or economically disadvantaged areas, it was almost in every single provision. So there was a significant understanding or a reasonable understanding of the impact of the pandemic on rural areas or underserved areas. One last question I'm going to ask before I jump to the small business provisions. And this one is I'm not meaning to jump ahead of the others, but do we have any indication or have any knowledge, and I think I know the answer to this, that whether they will execute that waiver or not relative to the TIP piece?
We are going to be actively working to make sure that happens, and hence the reason why we're doing the survey. So we're suggesting that you go to that survey link to fill out if you've had these protocols in place or have developed as well, so we have more information to show them. And the second thing that we're very cognizant of right now is that we can show as an industry we are not going to abuse the authority of the intention behind this. And that's why we're really focusing a lot on this as well. Those are going to be the things that we're going to have to be able to show CMS to predicate them exercising this waiver.
Yeah, I jumped back a couple slides just so you could see the AAA put out yesterday, late afternoon, a link to a SurveyMonkey relative to treatment in place. So important. And the link is also in the chat feature at the very, very top when we started the program. So I just wanted to make sure that you saw those. And we will, as I said, we'll grab all of these questions and make sure that we get back to those folks who asked the questions that we weren't able to tackle. It looks like Amanda kindly put the SurveyMonkey link back in sort of in the latest part of the chat feature. So another part of the legislation, the Paycheck Protection Program. I know that many organizations took advantage of the Paycheck Protection Program. There were some additions to the Paycheck Protection Program in late December under the Appropriations Act that added the ability for 501c6s to take advantage of that, provided they weren't doing a whole bunch of lobbying. But really, these latest, the $7.25 billion that was added to the PPP program did not extend the application date for some of those second draw loans or first draw loans past the March 31st deadline. But really, this latest piece of legislation was geared at those really smaller businesses. So, I think there were a ton, and I know many organizations who were able to avail themselves of those second draw loans. So for sure, again, these are loans provided they're forgiven that essentially become interest-free grants. All right. In addition to that, one of the other SBA provisions that was included in this were additional funding, $15 billion for the EIDL, or the Economic Injury Disaster Loan Program, which are grants that typically will get rolled into loans that will typically get rolled into a PPP loan. So it'll be really, this was geared at for those folks who applied for those EIDL loans that did not get approval of that EIDL loan in 2020. That doesn't mean that if you're eligible for it now that you can't apply. You certainly can, and you just go to the SBA website. You can get more information. And as we said before, probably 6-8 months ago, when the PPP loan program first really was launched, just keep in mind that while I think there were something like 4,100 new small business lenders that were added to the rolls after the initial PPP or the CARES Act was passed. So just recognize that depending upon how often or how regularly or I think by now most banks are very familiar with the SBA process. Just recognize that this was a really streamlined process. The typical SBA process, not so easy, very, very involved. So if you haven't already taken or looked at this PPP loan or the second draw loans, you really should. One of the pieces they added here, and I think it really does make sense, because if you weren't listening to us or if you didn't have other resources, a community navigator, really, they under the legislation, they established or appropriated money for or to create a community navigator that will help socially and economically disadvantaged business navigate the different sources of funding that might be available to them. So be sure, if you're unsure, remains to be seen what this navigator program will look like. But as we get more information, we'll let you know. Certainly in the meantime, if you have questions about how to tackle some of the stuff, you can always call us. And then there were some increases in small business credit initiatives. And again, the 2.5 billion of that really dedicated towards economically disadvantaged, socially and economically disadvantaged businesses. A huge component of this latest legislation really focused on mental health and substance use and abuse. And I think, part of that is, given how long now so many healthcare providers, EMS, public safety folks, and other frontline essential workers have been dealing with the pandemic and its related effects, not surprisingly, almost wish some of this funding had come in earlier, because for a lot of folks, the damage has been done, and we're now going to be digging out of a hole. But 80 billion in grants and contracts to health professions, schools, for developing and or educating other, and hopefully providing for the workforce that doesn't yet exist. We know many of us are really struggling with recruiting individuals to come in and work in EMS and the other allied health professions. This really is getting at educating folks for not only those programs, but then also providing education for folks relative specifically to mental health issues, suicide, burnout, substance use, etc. Asbel, do you want to talk briefly about the waiver authority under 1115 and 1915 relative to mobile crisis teams?
Yes, I'm not going to go into a lot of that, but I know there's a lot in the industry that are doing forms of mobile healthcare, forms with crisis management teams out there. This provision actually is a fantastic provision that is allowing Medicaid and giving Medicaid under Section 1947 of this of the American Rescue Plan, that allows states to put this stuff to handle mental health crisis with these crisis teams. And it gives them the ability, guys, for a different funding source outside of their federal match. And most of y'all know I can get real nerdy about this, but basically what it's saying is it's giving the states more money from the feds to put these programs together. So because of that happening, it allows them to reimburse on the crisis management team. You could have a psychiatrist, you could have a social worker, you could have a paramedic with additional training that goes out, helps triage the patients, and then directs them where they need to go. This allows states to get paid at an 85% 15. So basically, instead of, say, for instance, their normal FMAP was for every dollar they get up, they get $3 back. They now get 15, 20% more of that back now to fund this. So for every 15 cents they send up, they're going to get their 85 cents back. So this allows them to get more funding to help pay for these things. Now, it's not to supplant what they're currently doing, it's to supplement. So a lot of states are moving this into their either an 1115 waiver or a 1915 waiver. And many of you guys are doing this on a national basis. So I just wanted to draw your attention to that. This is something you'd be working with your states on. You may already be working with your states on it. Just know there is more funding now available to them through this provision. And it goes through 2026, I believe, and what have you. So that's just a really quick thing to pay attention to as you're working through this stuff. Another avenue for reimbursement.
Yeah, appreciate it. An additional $20 billion for the CDC for national evidence-based education awareness campaign for healthcare professionals and first responders, sort of encouraging prevention and support for mental health, identifying those risk factors, reducing suicide, substance use disorders, burnout, etc. And in particular, with a focus, again, on that rural and medically underserved, those medically underserved grants. So where or how this will play itself out, of course, we don't know yet. We'll see, I'm sure, in the coming days. I know that I think the president signed that piece of legislation today or yesterday, ahead of schedule. Actually, it was yesterday, ahead of schedule, expected to be Friday. So we'll have more on this as we see additional material from the CDC. Again, what we know back in December when we presented on the Appropriations Act, we talked about the fact that, of course, the FFCRA, or those emergency paid leaves, expired at the end of 2020. There was an extension of the ability for an employer to recover the associated tax credits for those leaves through the end of March. Well, they've now extended that out through September 30th. Of course, under this, there is still no requirement that you provide additional leave. If you provided leave already and you've exhausted the leave provided under the FFCRA, there won't be additional tax credits for, let's say, another 80 hours of sick time. That's not what's intended here. If you previously did not provide paid sick leave to those folks, really this is trying to make sure that you recover the tax credit so that it becomes essentially a cost neutral provision for you. So the one that I've been getting a lot of questions on, and Brian and I spent probably 30 minutes on this earlier today, and it is one of the ones that, despite two lawyers looking at this, and one of us in particular being an employment lawyer, we spent a fair amount of time thinking that this was worded really difficultly, because initially when the employer retention credit came out, of course, you couldn't take advantage of the PPP loan and the employee retention credit, but that was modified late last year. And initially, of course, you had to see a 50% reduction in any one quarter in your gross receipts over the same quarter in the prior year, which that was modified late in under the Appropriations Act to then be up to, if you saw a 20, and I say up to, the reduction in your gross receipts only had to be 20%, and you would be eligible moving forward in 21 to take advantage if that same quarter in the prior year you saw that reduction. So the refundable tax credit is against the employer share of Social Security taxes against an eligible employee wage, which can include the portion of those health insurance premiums. So it's for 2020, it would be a 50% tax credit on those wages, or in 2021, a 70% tax credit on those wages up to $10,000 per employee wages. So the max credit in 20 would have been $5,000. The max credit in 21 would be $7,000 a quarter. So that is this extension through The rest of this year is actually going to be, I think, and Brian, I don't know if you have any comments on this. This really is one of the areas that if it doesn't apply, unfortunately, to governmental entities, but for any of the nonprofits or privately held organizations, this is actually a pretty good financial relief effort. Do you have any comments on that?
Yeah, I mean, the only thing I would say is it's really just a question of the math. To compare this, and a lot of people do sort of conflate this with the payroll tax deferral. The payroll tax deferral allows you to defer a 6.2% of an employee's wages for what amounted to 24 months and then pay it back over time. This allows you to get 50% of their total wages back, use it to offset the amounts you would have owed for their payroll taxes, and then they will write you a check. It's a refundable tax credit for the amounts over your existing tax liability. So, in theory, this could be $28,000 per employee, assuming they're making, $10,000 per quarter per employee. And 6.2% of that will be paid in payroll taxes, but the other 64% comes back to you directly. So this is definitely the one that if you have to ask your accountant, about, this to me is the one, right?
Yeah. And for organizations, one of the things that I do know is not everybody uses, if you use a payroll service, your payroll service should be well aware of this. In many instances, payroll services actually remit on behalf of an employer those monies to whoever you're paying your taxes to. So they should have enough information. But I also know that many of you on here do your own payroll. So if you use an organizational tax accountant, the accountant should know about this and be able to provide advice. But certainly, I know I've spent a lot of time over the last week and a half and have time scheduled out next week already to talk to organizations about how this works. So we could spend a lot of time. And like I said, Brian and I spent well over an hour earlier walking through how it's so confusing, because when you go to the IRS's website, it says right at the top, this doesn't reflect the changes made for 21. And I thought, it's March. By now, there should be somebody at the IRS who can say, here's the rules for 20. Here's the rules for 21. Why? It would be very easy for you to go on there and go, what, only 50%? I thought they told me 70%. The reality is, I'm not sure why. This is one area in which I think there's room for improvement. As many of you know, of course, there have been the extension under this act of the pandemic unemployment assistance, which provides that an additional $300 right now. It was scheduled to expire, I believe, in June or July. It's now been extended out through September 6th and exempts, in addition to that, a $10,200 in benefit from your 2020 federal income tax for households making less than $150,000 a year. There were a lot of also child credits and other credits that were available. We didn't tackle those because certainly that may not apply to everybody. But just so folks are aware, and hopefully I think most EMS organizations are hurting for help. So we're not in that position where we've got a lot of folks out on unemployment, but just so you're clear, those provisions do continue. This is the one that, of course, as an employment lawyer, I'm incredibly interested in. As many of you may have seen, the executive order signed shortly after President Biden took office saying, hey, we're going to get serious about workplace enforcement and workplace safety. And so what I would say is they added $150 million. In the grand scheme of things, actually, that's not a ton of money. I'd take it if someone handed it to me. But the reality is this is increased worker protection for OSHA oversight and UI regulatory, so unemployment insurance oversight, through September 30th of 2023. I will tell you, I have seen an uptick for certain in OSHA-related complaints, in particular related to respiratory protection programs, fit testing, initial fit testing, medical questionnaires, et cetera. We can talk about that, and we did talk about it in the HR webinar last month, but we can talk more about that. If you have questions, certainly you can send those questions over to us. Question, Brian, I don't know if you caught that in the Q&A. Is there a concern that entities received previous monies based on significant reduction in revenues that were tied to reduction in transports? Might this reimbursement be for the same thing?
Talking about the TIP?
I don't, mind, Richard, I don't know if you'd mind dropping in an additional clarification on that question, certainly we can get back to you on once you comment. There was another question in here again about Troy about is there a limit on company size for the employee retention credit extension? So interestingly, Troy, great question. I've seen or saw some guidance that suggested it was for employers of 100 or less, but when you go to the IRS's website today and you type in, is there a restricted employer size? It says no. So,
but just to clarify, so there is a distinction they draw between quote small and large employers,
yes,
which determines the amount of the credit you can get. Originally, that dividing line was set at 100 employees, I believe.
Yep.
And in the October changes, they upped the threshold for a quote small employer to 500 employees. So the net answer is if you're over 500 employees, you're going to be subject to the quote big company rules, which are slightly less attractive in terms of the size of the credit, but either way you will be eligible, assuming you meet the revenue drop requirement.
Yeah, and again, if you have an organizational accountant, and I'm going to bet Troy's organization does, that would be the one that you would want to just touch base with. But yes, so the answer is there is an impact in what the credit is, but you're still eligible.
No disqualification based on the number of them.
Correct. So Asbel, public health workforce in the 7.66 billion that was, actually it was more than that. Actually, it was put over for this. Do you want to cover those provisions? And
sorry, I'm trying.
No, you're fine. You're fine.
With all these questions going back and forth, we're all trying to help out with. So the 7.66 billion for sustaining a public health workforce. This is the funding, guys, that is going through local, state, all the monies that are being awarded through that for emergency medical services is specifically listed. But I will tell you this, if you're a governmental entity that is employed by a government, it's going to be easier to get access to that. If you are private, that is associated with that, you need to start having those conversations now. The way that they're distributing these funds to state and local territories, everybody is getting funding. And there is actually a spreadsheet on this in these local communities and how much money that they are getting. I mean, if you are talking to your city council, if you've got relationships with your mayors and what have you, you need to make sure that you are not forgotten about. If you are a private entity and how they are working and looking at that piece as well. But I will tell you this, and this is my jaded thought coming through the process, that if you're a private entity coming through that, more than likely you're not going to get anything relative to the funding that's coming through the local and state if you don't nuance that a bit. That's just me being jaded, but it's going to be dependent upon your jurisdiction and what you're looking at. But this funding for the public health workforce and the funding that's coming through this is maneuvering through the local and state governmental piece of it. I mean, those funds that are allocated, and that was a big thing to make sure that the first responder community was addressed, and specifically it mentions our personnel as well. So I would be having those conversations with your local governing authorities now. And that's going to be distributed through U.S. Treasury.
Yep. And it's important. I think one of the things that I also appreciated in this latest piece of legislation, but the devil will be in the details again, how that money is spent, was there was a great number of mentions about public service organizations, EMS. And so, what will be interesting is to see how those monies make their way, because as we know, and when we get to our the slide after next, when we talk about FEMA money, we know that for many of our folks who might not be governmental entities, the access to those funds is somewhat limited. But again, the best way to ensure that you're at the table is to start those discussions, try and get the invitation to the table right now. So one of the other things that there was, as you would imagine, there were tons and there was a lot of discussion about the 20 billion in the establishment of a national COVID-19 vaccination program, as well as the 7.5 billion to prepare, promote, distribute, monitor, and track vaccines. I think that second dollar figure is really getting at promoting the reasons for folks to get vaccinated. We know that in certain communities and or it's become very political whether folks are going to get vaccinated or not. This was one of the ones in which they were trying to raise awareness and education surrounding the vaccination distribution and administration. I think this, given that many of our members are participating in vaccination administration, this too would be another opportunity, again, where organizations who are taking advantage or participating in that, this is an opportunity. So last but not least, Asbel, do you want to tackle the FEMA, or Brian, the FEMA provisions?
Brian?
I'll jump in and I'll turn it over to Asbel. So, there are additional dollars here to just sort of support the existing ongoing vaccination efforts. There is a bit of a debate going on as to whether or not the monies for the National Guard are intended to support the National Guard's role in overseeing vaccinations, or oversee their work, for instance, in providing additional security in the Capitol. Again, money for PPE for frontline healthcare workers. Minor things or relatively minor things like funeral assistance for those individuals that can't otherwise, pay for those things. I think in terms of the impact on us, though, those last two bullets there are probably the ones that are most directly applicable to our industry. There is $100 million that will go to fill in the Assistance to Firefighter Grants program, and then an additional $200 million for the SAFER program. Now, for those of you that are not familiar with it, the SAFER program, among other things, is used to provide funding that can be used by municipalities and other governmental entities to either retain firefighters that would otherwise need to be laid off due to financial constraints, or to, and this is where I think this is really intended, is to rehire those firefighters that have previously been let off. So there's hope for Scott, I don't know if he's still currently on his local fire department's payroll. I know he was right around vaccination time, but
yeah, as of the last few months, I did finally decide to retire from my fire department job because my wife was volunteering to cover a COVID hospital, and one of us needed to stay healthy. So I was lucky.
So for the rest of you that are municipal fire departments, there is 199,900,000 and some odd thousand that is left out there to rehire your own firefighters. Presumably Scott will get his. Yeah, I mean, generally speaking, there is a ton of money here that is going to support FEMA's missions, the humanitarian stuff, the food stuff, et cetera. All of this is not necessarily directly related to COVID, but represents a recognition that FEMA is the front line of these things, and that FEMA's resources were really, really stretched at the beginning of the pandemic. So I'm going to put the best possible political spin on this. If you want the other side, you can certainly turn on Fox News at this point and get it. So.
The only other thing that I would suggest here is I know a lot have been involved in the FEMA or subcontractors to individuals that were involved with FEMA. So if you're doing a lot of vaccination work or whatever, here's another avenue for you to understand what's available there as you are reaching out to those different sources. So between the making it a mandatory requirement to cover the administration fees for the vaccines by Medicaid, because you had some states, namely, those are going to be the states that might be a little redder, that didn't want to pay for the administration or some of the FMAP component. They've now said that FMAP is 100%. So that means the federal government pays everything related to that. So if you're in states like that there was an issue with that has now been taken care of. So you should be receiving reimbursement if you're doing COVID vaccinations. And then remember the FEMA stuff. As well for some of those other areas for you that may be looking at alternative reimbursement sources outside of just transportation. This is another where they put another $50 billion into that disaster relief fund. So that'd be the only other thing that I would. And if you've got the SAFER grants, this is put some more money into those SAFER grants.
And so a quick question that came up in the chat is, can you provide detailed steps for taking COVID vaccine clinic reimbursement fees? I know you and I did a webinar, Asbel, what was it, maybe a month ago, where we talked about billing for vaccinations. how about, and maybe a few words or less is, or are there resources that you would direct this attendee, Sandra, to relative to seeking reimbursement for the administration fees?
Yeah, you know what? If you will send me an email, I'll send you the links that you can go to that will walk you through how to set yourself up for the vaccine reimbursement piece. We'll do that and get you over to some webinars that you can kind of read that take you through that, but pretty succinct and get you through and kind of walking you by step process.
And I know I can see that Brian is typing an answer to what looks like our one last outstanding question for Chad. I don't know, Brian.
But I think I'm just going to save myself the trouble of typing. So I think it's a good point.
Should I read the question for him first?
I think you should.
Yeah. All right. He says, I know you're putting an emphasis on community-wide standards, but doesn't this create a dilemma on having community-wide protocol restrictions that apply a universal transport standard, yet we are dealing with one particular payer who will offer payment for treatment at scene and others who will not? What do we need to do to ensure commercial/Medicaid are going to recognize this as well? It's a great question.
It is. I think if I had to put myself in the mind of Congress in enacting this, I think what I would say is what they are recognizing is it's really a chicken or the egg problem, right? I mean, I think they're assuming that the community protocols were changed in order to respond to the exigent circumstances involving hospital capacity. And now they're addressing what we've created as an unreimbursed care situation by giving CMS the authority, if it wants to use it, to pay you in that circumstance, right? In terms of what we need to do to get the commercial payers and Medicaid to go along with it, the answer is you just need to push them. Now, many commercial payers already pay for treatment in place. Anthem is a notable example across, at least half the states at this point, right? So the underlying argument related to treatment in place is far broader than what the waiver is here. That argument is, all things being equal, you would rather treat someone in place than take them to the ED because it's cheaper to whoever is ultimately paying for it, right? What Congress is doing here is saying, we're testing this concept in ET3. We're not ready to announce that it's worked or not worked. And that's why we're not willing to go all the way to adopting treatment in place under normal circumstances. But given the exigency of the current circumstance, if CMS feels it's appropriate, we're not going to let the existing law be a barrier to them doing it on a temporary basis, right? So I think that same argument could be made or should be made to the commercial payers and Medicaid, right? And in the case of Medicaid, it's the same argument, just it's a little bit easier in the sense that you're not even paying full freight for it, right?
Yeah, and once they do the waiver, if CMS exercises the waiver and then pushes it out, then you would just work with your state to adopt the waiver, just like the many that they've already done.
So someone did ask that question about South Carolina, and the question was, would the state need to adopt its own 1135 waiver? More likely than not, yes. In theory, it would technically depend on the verbiage CMS uses when it adopted the nationwide waiver.
Correct.
Right. But if they are going to adopt it on the Medicaid level, then they would absolutely need to either amend their state plan permanently or get a waiver to do it on a temporary basis.
Yeah.
Well, and I think I know does a third party billing company bill for those fees on the administration fees? And I think the answer is
the question of what your contract with your client says.
Right. And again, just, email into hello@ or the info@ambulance.org. We'll send you out the links to those webinars and or other resource documents that you can use to learn more about the actual ins and outs of billing for vaccines. So I know we had we had 230 some odd, 240 some odd attendees. So I cannot thank you enough for probably one of the most questions we've received in our webinar, but it's a good thing, right? We don't know some of the answers yet, but as soon as we have them, we will let you know. The other thing is your questions are a great way for us to also make sure that when we're talking with those lawmakers or those regulators, that we're able to take information that we may not know because we don't operate in your area. So thank you to everybody for those questions. Please
fill that survey out on treatment in place.
Please fill the survey out. Please keep the questions coming, but fill that survey out because that's something that as we go back and talk with CMS, we want to make sure that we have an understanding, at least from our own membership and those of people attending the webinar today, what's going on in your particular local environment. So with
This
that,
law sets the ground rules. We now need to work with CMS to set the actual, the actual ground rules. This law just simply gives CMS the ability to create the regime, right? And the more we understand about everyone's particular situations, the better we can help craft CMS's response to make sure it benefits everyone.
well, and I want to say I got a thank you from one of our attendees, Greg. Thank you so much to all of you, really, because we know that it takes a lot of time out of your day to come and attend a webinar and actually pay attention, possibly. And so we appreciate it. If, of course, all of us are here, so sort of the value of your membership is that you get to pick up the phone and call any one of us anytime. If you consider that a value, for you might get stuck on the phone with me for a while. But thank you very, very much. Again, just a reminder, do that. Please do that, that SurveyMonkey, as well as Monday, out with the digest will be the recording of this webinar, as well as a copy of the slides. So just keep your eye out for that. And with that, I thank you all for hanging on a Friday afternoon in a day when it's like in the upper 60s here in the Northeast, which usually means everybody cuts out early. Asbel's used to it in Austin, but we don't get it too often here. So thank you everyone for attending. Asbel and Brian, as always, thank you very much. And Maria and AAA, Amanda and Meg at the AAA, thank you so much for always providing us the platform. So with that, thank you and have a good afternoon.